Good afternoon. My name is Dr. Danny Melker. Today we're going to be talking about biologic shaping with particular emphasis on the treatment of the furcation. When doing this procedure, it's critical as to the type of burr that we're going to be using since we will be working on the root surface. The burr on the left has too much taper and is rounded at the tip so that it can in fact ditch the bone. If you look at the burr on the right, it has a flat end and only a 4-degree taper. This is critical because when we are using the burr at the bone to tooth surface, we are not going to ditch the bone, and we will, in essence, remove all margins on the tooth surface, which is critical to future preparations by the restorative dentist. When looking at the three burrs in this picture, you'll notice the burr on the left has a severe taper, and this would create major problems as far as removing too much tooth surface, as well as again ditching the bone. The burr in the middle, though getting to be more ideal, has a rounded tip, which could be an issue again when we're trying to correct the interface between the bone and tooth surface. The beauty of the burr on the right is it is end cutting with only a 4-degree taper. Used properly, it will create a perfectly smooth tooth surface, 360 degrees, and where the bone meets the tooth surface, there will be no margin and simply a perfectly smooth environment for future healing of the biologic width. You are looking at a burr kit made by Access Dental. You can buy it at Sullivan & Shine. The kit has the advantages of the proper burrs that we need for biologic shaping. There is a coarse diamond that we start with, and we simply move down to smoother burrs to create a smoother finish on the tooth surface. I would also recommend using diamond round burrs when doing your osseous surgery and not carbide burrs, which could be a little too aggressive. Here we're looking at a case post-osteectomy or contouring of the bone. You'll notice that interproximally the bone is in a more coronal position than the buccal bone. This is called a parabolic architecture. This is critical since the soft tissue will cover the bone upon suturing, and it is important to have the bone mimic the soft tissue. Once we allow for sufficient healing of the biologic width, which could take 12 to 14 weeks, there will be minimal probing because of the close adaptation and mimicking of the bone to the soft tissue. Let's discuss now the furcation and the importance that it plays in long-term maintenance of molars. What you're looking at is a photograph of almost the ideal restoration. The furcation that was removed is now still not placed in a final restoration. Over the next several slides, we'll see the importance of never placing a furcation back in the restoration. In this case, we're using metal struts because it allows for thinner material and better contouring. Again, as we discuss this procedure, you'll see how important it is to have the lab on board with you in final preparations of these teeth. This is taken from the Dental Clinics of North America, 1998. And in essence, from left to right, the surgeon is doing an apically repositioned flap because of the furcation involvement. He has done, in my opinion, nothing to treat the cause, which is the furcation, and in essence, all he's done is leave the problem present, and future bacteria can continue the breakdown of the furcation, which will cause a deeper probing horizontally and eventually possibly the loss of the tooth. You'll notice from the arrow, again, that the furcation is still present and has not been treated. When looking at teeth, it's important to understand where the pulp is in relationship to any tooth structure that you're going to be removing. This is a cross-section of a lower molar where we are measuring the distance from the outer portion of the tooth to the pulp, and it's well over 10 millimeters. This gives us assurance that we should not ever really run into any pulpal problems when doing this procedure properly. Now you're looking at a coarse diamond burr and how it should be applied to dealing with furcations. We do not really want to start with the furcation and make it deeper, but rather work on the adjacent root surfaces. By doing so, we're going to blend the root surfaces into the furcation, and then at the end we will remove the lip so that now there is a total smooth hourglass shape appearance to the furcation area with no lip remaining. The arrow simply points to the fact that we are starting on the adjacent root to the furcation and not in the furcation initially. We have now proceeded to the superfine burr, but as you look at tooth number 30, you'll see that the tooth is perfectly smooth and the lip of the furcation is now removed. By the arrow, you can clearly see that the old margin is removed, which is crucial in biologic shaping. Here we have a rather severe furcation issue related to a old margin that was located within the furcation. You'll also notice it's a very narrow furcation, and again the margin and the furcation meet. The depth of the furcation horizontally is significant. So the crucial part of the procedure is going to be is for us to be able to remove the furcation for a future restoration. Again, we start with a coarse burr working on the adjacent root surfaces to the furcation. You can also note that there is already reverse architecture from the previous problems on the tooth surface. We have now shaped the tooth totally. You can look and notice that you'll see a portion of the occlusal surface missing. This took place when the endodontist was doing his root canal for previous decay and did not remove the provisional. In doing so, he had no landmarks and was too far to the buccal. You can also notice from the arrow that as we progress into the furcation that the bone usually is in a coronal position. This is critical because it means that if the margin is too close to the furcation, initially, if we simply start doing conventional crown lengthening, we may in effect not even solve the problem because the margin will always be too close to the bone within the furcation. The photograph on the left simply shows a superfine burr, as I discussed with you, working on the root surfaces to prevent a very deep remaining groove and trying to create a nice smooth hourglass shape. On the right, you can see the diamond round burr blending the bone into the furcation area to create a parabolic architecture and no ledges. The final result shows you, again, a parabolic architecture on both the mesiobuccal root and distal buccal root. You can notice the bone in the furcation in a more coronal position. How we know when the procedure is completed is simply to take a probe, place it at the coronal portion of the bone in the furcation and move coronally. If it does not catch anywhere, we know the lip of the furcation is totally removed. The arrow points to the bone in the furcation, and again simply take a probe, and if you feel no catching, you know the bone is removed. In June of 2003, in the Journal of Perio, an article was written about the location of the furcation in relationship to tooth surfaces. To make it simple for you, as a restorative dentist, if you're going to replace a crown with a margin that is subgingival in the furcation area, you can pretty much expect that the next margin will be in the furcation. So in essence, what this means is you need to do either crown lengthening or biologic shaping. We're going to be showing the advantages of biologic shaping because in essence, we're not going to be removing bone, but in fact trying to preserve the bone by removing the old margin and the furcation. This is a case from the early 80s. The patient did require new crowns, but she did not want to undergo them. She had significant bleeding, and my concerns for the crowns would be whether there was decay underneath, which would compromise any procedure we did. We discussed with the patient her options and explained if we hit decay in correcting the problem, then new crowns would be necessary and possibly even retreatment surgically. When we reflected the tissue, we noticed there to be the primary cause of the problems, iatrogenic dentistry, open margins, cement sepsis, and you can see the reverse architecture of the bone. If we look at tooth number 19, you can see that the crown is approximating the furcation, and there is a furcation involvement. I then followed the routine that I do normally with biologic shaping and corrected the issues with the existing crowns. We also significantly barreled in the buccal furcation in the crown of number 19 as well as number 18. 20 years later, you'll notice the optimum health in both the furcations of 18 and 19. No decay was ever found or ever occurred. Again, the key to the procedure was we removed the cause and not the effect of the problem. Because the margins are all now supragingival, the tissue is perfectly healthy. Here we have a situation with a molar where we have a periodontal abscess. When reflecting the tissue, we see the real cause is that the existing crown margin ends in the furcation. The arrow points to the location again of the margin. In essence, what we did was simply remove the cause, which was the margin, and create an environment that there was no furcation remaining. Again, as I told you, you could take a probe from the osseous in the furcation to the occlusal surface of the crown and not catch it anywhere. In 1981, you see we completed the surgery, and in 2002, 21 years later, the tooth is still maintainable and functioning beautifully because we removed the major cause, which was the old margin in the furcation. You can have a supragingival margin, and in fact, when you open it up, you can find that it is in fact located within the furcation. Again, going back to the Journal of Perio 2003 article, these furcations are very close to where we would be with our new margins when replacing an old restoration. I can't tell you the importance of working with a periodontist when you're dealing with molars that have subgingival margins and you're going to replace them. So in essence, I did take a burr and simply remove the furcation in the existing crown, solving the problem. Again, we're treating the cause and not the effect. You can see by the arrow that the old margin is in fact located in the furcation. This is a case where a previous restoration was placed on tooth number 14. This was done by a very competent restorative dentist, and we are now to treat number 15. When I opened up the area, I found there to be the existing margin of number 14 located within the furcation. You can see by the arrow that there's now a defect and the bone is reverse architecture, but in fact the margin ends right in the furcation. On the right you can see the depth of the furcation horizontally. What we did, as you've seen on previous cases, is simply remove the excess porcelain, metal, and again create an environment where we could take a probe from the inner aspect of the tooth in the furcation area and move coronally without catching any portion of the tooth. In essence, the furcation is totally removed. You're now looking at one of the most important slides that we'll be discussing today. You'll notice from the arrow that the existing margin of the old restoration is finished right at the furcation. You'll notice the reverse architecture of the bone and the furcation involvement present. So what we're going to do, as you've seen, is take the burrs and simply shape both the adjacent roots and then remove the lip of the furcation. The arrow points to the height of the bone as we move deeper into the tooth, and you'll notice again the coronal position. How I know that the tooth has been sufficiently prepared is by taking a probe at this point and moving it coronally. If there is no couching of the tooth surface, then we know the furcation has been totally removed. Here is the final restoration with porcelain fused to metal, as well as supragingival margins. What is more important is that you can see that the furcation has been barreled into the occlusal surface. This is critical, and we will discuss it in the next several slides as to the importance of the lab understanding barreling in of furcations. This can be both important for the restorative dentist and the hygienist. You'll notice that the probing in the furcation area on tooth number 19 is 1 millimeter. It could be questioned as to why treatment would be undertaken. However, upon reflection of the tissue, you'll notice that in fact the margin ends right in the furcation area. And in fact, the probing on the right shows a severe furcation involvement. Think in your mind that if you were to take an impression or seed a restoration, what would fill the furcation? Well, if you're seeding the restoration, it would be either cement or bonding material, both which could cause future breakdown and loss of the molar. The arrow points to the fact that the margin ends exactly in the furcation area. What we did again was work on the root surfaces adjacent to the furcation and then barrel in the furcation to remove the lip. You'll notice also that the tissue, when sutured on the right, is placed just coronal to the bone so as to create primary healing, and this greatly reduces the discomfort for the patient. This is the day of impressions. You can look straight down the occlusal surfaces and see perfect tooth structure, 360 degrees. What's important as far as tooth number 30, or the first molar, is that you can look from the occlusal surface to the tissue and not see any tooth surface in your way. This is going to be critical because the lab must follow these contours exactly. As far as the impression, we have a number 7 Siltrex core just placed into the sulcus. The preparations are light chamfers, and in fact, we're going to leave the margins supragingival. The final restorations are placed. You see an onlay on tooth number 18. Tooth number 19 has a barreled in furcation with an all porcelain restoration with supragingival margins, as well as number 20. I want to go back and simply remind you on the previous slide I said tooth number 30, where it is in fact tooth number 19, as you can visualize from this restoration and location. What is also important is, if you remember, we severely barreled in the furcation, yet you'll notice from the x-ray there is no endodontic issue. If we follow proper biologic concepts and locations of pulps, we should never really have an issue with furcations and creating endodontic lesions. We're now looking at tooth numbers 2 and 3, and again what we're going to do is deal with the location of the margin in the furcations. We're going to try not to use the margin as our determining factor in how much bone we remove, but rather we're going to remove the margins first and then see what we have to do to create a space for the biologic width. So by simply shaping the old margins to remove them and then removing the lips over the furcations, we've totally solved the problem without creating a massive need for bone removal. You'll also notice, as I've discussed with you at great length, the parabolic architecture of the bone on both 2 and 3. The tissue is then placed back just coronal to the osseous foundation, so as again to get primary closure and far less discomfort. The final restorations are both supragingival, and if you'll notice, the furcations are barreled into the occlusal surfaces. Both restorations are all porcelain restorations. As you know, we deal with furcations on the mesial and distal with upper molars. Here is calculus located on a first molar. What I try to do with these areas is to work on the adjacent tooth surface to the furcation. So we would be working here on the distal buccal area and the palatal area to try to blend the tooth surface and remove the furcation before we start to burl in the furcation. In this area, we're dealing with tooth number 2, and we can treat it like the buccal surface of a molar. So in essence, we're going to burl in the furcation, still working on the adjacent tooth surface of the furcation. Here, after I've been spending several minutes burling in the furcation, you can see calculus still present. This is not uncommon because these areas are filled with plaque and calculus because of the inability of the patient and hygienist to clean the areas. You can see finally a smooth tooth surface. Because this is the distal of a molar and it is an area that the patient can clean, I am not concerned with the burling in of the furcation. As I said, if this was a first molar, I would try to remove the furcation by working on the adjacent root surfaces. There is the furcation burled in by the location of the arrow. We then go for primary closure with our distal wedge, and you can see the final restoration again, in this case all feldspathic porcelain restoration with supragingival margins and the distal furcation burled into the occlusal surface. This can be maintained easily by brushing. This is an important case from the standpoint of thinking about conventional crown lengthening. Because of the location of the margin to the bone, if we were going to crown lengthen this tooth conventionally, we may have a difficult time ever creating a space for the biologic width, and in fact may simply create so much damage that the tooth would be rendered hopeless. So as we've been discussing through the entire presentation, is we're going to start on the tooth surface first and remove the old margins. By doing so, we can then determine how much bone we'll need to remove to create a space for the biologic width. So as you can see from the picture on the left to the right, all we've done is reshape and remove all old margins, thereby correcting the problem, which was the location of the margin, without destroying excessive bone. You will notice the parabolic architecture of the bone on the right. And again, we could take a probe from the bone in the furcation to the occlusal surface and never catch any area of the tooth surface, knowing we have in effect totally removed the furcation. The final restoration is placed. In this case, it is a PFM, but again, you'll notice that the furcation is burrowed into the occlusal surface and no hydocontors are placed. This is critical because if a hydocontor is placed, then we're putting back the furcation. This case is going to be an excellent one from the standpoint of your lab. This is an old case done around 1990. When we lay the tissue back, you can see the old margins running along the tooth surface and in fact approximating the furcation. Once the procedure has been completed, you can see the perfectly smooth furcation and again the bone coronal in the furcation. This is the day of impressions. If I was a restorative dentist, I would be in dreamland because it would be impossible to miss this impression. We are using a number 7 Siltrex cord simply to allow for a space to be located in the final impressions for the lab to be able to trim the dies without touching any margins. All margins in this case will be supragingival, and the tooth has been prepped to create a minor chamfer margin, and all furcations have been removed. Clearly from the picture on the right, you can see from the occlusal surface the tissue in the furcation, which means there's no tooth structure that could get in the way of the final impression. From the lab standpoint, we're going to have gold in the furcation areas as we discussed. This will allow for thinner material and better contouring. This procedure first was written about in the 60s by Dr. Maynard and Dr. Wilson. The occlusal view before the porcelain is placed, and then the final restorations with polished gold in the furcation areas and porcelain on the adjacent root surfaces to the furcations. The restoration's inserted with gorgeous tissue health and a perfect furcation environment for long-term maintenance. The question that is routinely asked is, why do you have to barrel into the occlusal surface? This is what happens when we do not follow this procedure. The lab put the furcation back in the crown, and thereby a bleb of tissue grew up where the furcation would be. Same problem occurred on the right side. In both of these cases, I had already done the surgery and recommended to the restorative dentist and lab the barreling into the occlusal surface. So clearly it is critical to have this accomplished. You can see from the arrow the very poor tissue health in the furcation. This case was sent to me by a prosthodontist where the periodontist had supposedly barreled in the furcation. In essence, the prosthodontist placed the crown, but the furcation was still left, and there is a bleb of tissue which is coming from the furcation which was remaining. Again, these pictures simply show what happens when we do not properly restore the tooth barreling in the furcations. Particularly the tooth on the right, even though there was metal placed, because the lab did not keep the furcations barreled into the occlusal surface, maintainability of the area was no different than had we left the furcation to begin with. Here is a beautiful restoration of tooth number 14. The problem is the lab did not carry the furcation into the occlusal surface when barreling in, and therefore we still have a little furcation remaining in the restoration. Certainly we can blame the lab, but remember, it's the restorative dentist's responsibility to prevent these type of occurrences from happening. A didactic explanation of biologic shaping in the furcation is shown in these two photographs. You can see from the occlusal view the X marks the spot of where the furcation is going into the tooth from a buccolingual direction. The picture on the right with the black area shows the amount of tooth structure that you would want to remove the furcation and blend the adjacent roots. Again, as I explained in barreling in the furcation, you'll want to blend the adjacent root surfaces so that you create a nice smooth environment as opposed to a deep groove in the furcation. From this view, a cross-section, you can see the importance of not placing the height of contour back into the tooth surface in the final restoration. The blackened area is the area that we would be removing and the portion of the tooth that cannot be replaced by the lab. The picture on the far right is how the final restoration should look upon completion. This is a perfect restoration for a barreled-in furcation. From the apical portion of the restoration to the occlusal surface, there is no furcation remaining, which allows for perfect maintenance by the patient. This is about to be an EMAX restoration. Though I love the work that was undertaken, and this is not my case, but in fact a restorative dentist doing his own surgery, the changes that I would make or where the errors are located, I would have, again, shaped the adjacent roots back lingually so as not to have such a deep groove in the furcation. It can be noticed, again, here, if you look on the photograph on the right, how deep the groove is. And when we look at this photograph, and particularly the photograph on the right, look how the crown location is related to the furcation and how deep the groove is. Again, the adjacent roots, if treated by biologic shaping, would have allowed for a smoother area within the furcation and a more maintainable area. I show you this case because it's important for us to understand that conventional crown lengthening can have a real problem when dealing with furcation areas. You'll notice the margin on the buccal surface of tooth number 3. The probe is somewhat inaccurate because it's measuring from the bone to the margin, but not really the location of where the bone is within the furcation. This picture is critical and should be studied at great length as far as where the bone really is located in furcations as we move into the tooth. I've removed the entire tooth surface as far as old margins, and now you can see the extremely high location of the bone in the furcation. It's quite coronal to where we thought it would be. Had we left the old margin and tried to remove bone to correct the biologic width issue, in effect we simply would have destroyed the furcation. By doing biologic shaping and removing the margin first, we can then determine how much bone we have to remove. Do not allow the margin to dictate how much bone you remove. Again, you can see from the photograph on the right that we have placed the tissue just coronal to the bone, which will allow for primary healing and less discomfort. The final impressions, and you can see the pore on the left. Notice how little tooth structure has really been removed by the restorative dentist. These are all feldspathic porcelain restorations. The margins are super gingival, and you see perfect fit and tissue health in the furcation area. Once again, the furcation is barreled into the occlusal surface in the final restoration. It is important again for your lab to understand that the restoration must mimic the tooth structure prepared. So you're looking at, on the left, the tooth surface prepared, and on the right, the restorations that are in place. From an occlusal view, you can clearly see that, in fact, the lab has perfectly mimicked the root surfaces or tooth surface with the existing crowns. The furcations, again, are barreled into the occlusal surfaces, which allow for maximum maintenance by the patient and hygienist. We're looking at a case of a prosthodontist that is about to take impressions. The patient presented post-surgery, and today he's going to remove the provisionals, marginate, take impressions for a completed case. This did not happen. He found there to be significant bleeding, probing upon his examination with inflamed tissue and irregularities everywhere. The patient was referred to me to redo the surgery. The original periodontist had told the prosthodontist that he had done biologic shaping. It is clear from the molar area that this tooth had never been touched. You can see on the buccal that, in fact, the arrow points out that the old margin ends right where the furcation is present, and clearly from the arrow on the right, you can clearly see the severe furcation and the absolute guarantee that this case would fail. What we'd like to do, as you can see from the pictures on the right, is remove the furcation in its entirety and create an environment that can be maintained by the patient and hygienist. The furcation was removed interproximally, so now either an implant can be placed or a fixed bridge. Also, please note from the photograph on the right, the tissue has been adapted for primary closure, which will create maximum healing and minimal patient discomfort. I'm going to take you through a surgical procedure of biologic shaping with particular emphasis on molars. The picture that you're seeing has old restorations with Class 5 restorations placed as the tissue moved apically. It is critical to note that when doing these procedures, it's always very important to have a maximum amount of connective tissue. The provisionals are placed, which are very important, and I will only do surgery when I have cores and provisionals. Reflecting the tissue, and in this case we did a split thickness flap. We can now see the problems with the molars where the margins end almost exactly in the furcations or are closely approximating these areas. I have taken my fat, as I call it, coarse diamond and have been smoothing the tooth surface to remove the old margins. Again, we did this on all teeth present. You can still see the periosteum present as we are only working on the tooth surface. Now we have peeled back the periosteum and are working with a diamond round burr to create the parabolic architecture that I've discussed with you throughout today's presentation. A superfine burr is then used to create a tooth surface that again is devoid of as much roughness as possible, create an environment that a chamfer margin could be placed by the restorative dentist supergingivally. I do not use this burr very often, but it is an ultra-fine burr with a 20 micron grid diamond, which creates a very smooth root surface. Once again, you can look and see that the periosteum has been peeled back, the osseous has been corrected parabolically, the furcations have been removed, and in fact, if you notice, the bicuspids are perfectly smooth also. Here we're doing what I consider to be one of the most important procedures for long-term stability of any perio-restorative case. We're adding an abundance of connective tissue. This connective tissue was taken from the palate and has been sutured in place to the periosteum. The advantage of doing periosteal flaps, or leaving the periosteum in place and doing split thickness flaps, is the ability to do more than one procedure at a time. In this case, I've been able to add connective tissue. You can see that it also goes all the way back to the distal buccal of number 31. The final restorations have 3 all porcelain restorations on 28, 29, and 30 with supergingival margins. And as you can see, tooth number 31 is an all gold restoration. Both numbers 30 and 31 have the furcations barreled into the occlusal surfaces. The concern is always, what about sensitivity? Here you can see pictures of molars that have been shaped with no restorative and yet no issues with sensitivity. Here again is a picture of 2 molars barreled in, reshaped, furcations removed, with only an onlay on tooth number 18. We are going to have a PDF file so that you can evaluate how to handle sensitivity at a later date, but in essence, sensitivity with biologic shaping is not an issue, and you can note quite clearly, look at the health of the furcation areas, which usually, from hopefully all the slides that you've seen today, is as nice, if not better, than anywhere else when treating cases that have comprehensive periodontal and restorative problems. Thank you for today's presentation, and I look forward to talking to you again.